It's a pleasure to introduce my new colleague and partner, Dr. Garni Barkhoudarian. Many of you have met Garni, and we go back a good 8 years or so. Garni trained at UCLA. He was a resident when I was still at UCLA, and then he completed he's had his finishing school in Boston, and we've been working together for the last 6 months, 7 months, and he's doing a great job. And he's going to talk to you tonight about hormones, headaches, and vision as it relates to pituitary tumors and skull-base tumors. So I think you'll find it interesting and hopefully entertaining, educational, and of course you can always interrupt and ask questions, and that's really the purpose here, is to give you all more information and a little camaraderie for what we've all been going through. Okay?
Well, thank you, Dan. I appreciate the introduction. And I got to say, I'm glad I did my year in Boston last year, because this year seems to be much, much, much worse. So as Dr. Kelly mentioned, today I'll be talking about pituitary disorders, surgical management of pituitary disorders in particular, and how they relate to how they present. So I'll be focusing on 3 main ways they present: headaches, hormone problems, and vision. And we'll talk about each in a little bit of depth. So, oh, wrong button here. Okay, so as far as disclosures, I have none so far. Let's talk a bit about the pituitary gland. Many of you know this, but just as a refresher, I'll fill you in on a little bit of what it does. The pituitary gland is known as the master gland. It is probably the most important hormone gland in the body. And it makes hormones that control pretty much any function of your body that goes anywhere from fighting stress, fighting infection, metabolism, growth, sexual function, procreation, all of the above. So it is in a really, really important area and has a lot of many critical functions. And it exists in an area that there's a lot of what we call high-priced real estate. There, in addition to the pituitary gland, and I'm probably not going to be able to point well with this laser pointer, but in addition to where the gland is, there's other structures. There's the blood vessels that serve the brain. 2 of the largest ones here, the carotid arteries, are just flanking the pituitary gland. And then just above the pituitary gland, and we're just seeing this in section right here, is the nerves from the eye, the optic nerves, and where they cross is called the optic chiasm. And that's just above where the pituitary gland lives. Just above that is the brain, and below that are the sinuses, and behind that is the brainstem, where functions such as just consciousness and blood pressure, breathing, all that stuff occurs. So it's a real critical area, and as you can imagine, problems in that area can cause any sort of symptoms related to these structures. So we'll go through some of these. So here's an example of what can happen. This is a normal pituitary gland right here, with the normal optic nerves above and the vessels around it. And here, imagine there being a tumor, and it compresses the normal gland, and it raises and compresses the optic nerves. So all of a sudden, your gland isn't working as well. You're not producing the hormones you need to sustain a normal life, and your vision is going. And people start talking about tunnel vision. We'll talk a little bit about that. But this is one of the main reasons patients present with pituitary tumors. So what are the symptoms? As I mentioned, probably one of the more common symptoms are headaches. And not many people think about it. Many people talk about headaches, that they have migraines, and they never put it together that there's something going on in the brain. Visual loss or disturbances. So visual loss, in particular tunnel vision, loss of vision in one eye or a combination of portions of the eyes, or double vision in a combination of that. Endocrine abnormalities, so hormone problems. There's one of 2 options. Either you have elevated hormone productions, as we see in Cushing's disease, acromegaly, or patients with prolactinomas, or pituitary gland dysfunction, so hypothyroidism, hypogonadism, etc. So low thyroid, low sex hormones. And sometimes we see a combination of them. We'll have too much growth hormone and too little testosterone, and we occasionally see multiple symptoms. And oftentimes there's a combination of the above, and it takes a number of people to figure out that they're all coming from this area, because as you can imagine, they could be very general, kind of run-of-the-mill type symptoms. And more, as MRIs are becoming more popular, people are getting scans all the time for a minor bump on the head, we're seeing more and more of these incidental lesions in the pituitary gland, and I'm going to talk a little bit more about that. So what can arise to cause problems in the pituitary gland? This is a diagram that one of my professors at UCLA had drawn, and it basically shows that there's all sorts of structures around the pituitary gland that can cause problems. Obviously the gland itself, but the coverings, the dura, can arise to meningiomas. The bone itself can cause various types of tumors. The milieu, so the inflammatory cells in that area, can cause problems into the pituitary gland. The nerves can be affected, and the brain can have tumors as well. So all sorts of different types of tumors can arise and affect the pituitary gland in that region. So what is the incidence? How often do we see problems or lesions in the pituitary gland in general? And you guys probably have heard this number before, but what do you guys think is the average number of people who have something going on at their pituitary gland? Anybody want to throw out a guess? Yeah, I know Sharma knows. 20%. 20%. Actually, that's almost exactly right. So about 17% of patients have some sort of abnormality in the pituitary gland. And we know this based on autopsy studies, and we know this based on radiographic studies where people just get routine MRIs for any reason. But of these, most of them are just incidental cysts or small little microadenomas that don't do anything. Patients never even know they had them, and doesn't cause any problems through their whole lives. So if that's the case, how many of these people actually have surgery? So let's ask, what percentage of brain tumors overall are pituitary tumors? Well, about 14% of brain tumors, or of primary brain tumors, not metastatic tumors, are pituitary tumors. So about 14% of our lives, in an average neurosurgeon's life, goes to pituitary surgery. We see more of it here because of the way our practice is organized, but that's about the average. And what is the incidence of surgery for these lesions? It's about 15.9 or 16 patients out of 100,000 people. So, and this is based on a national study for about 5 years period, covering about 97% of the US population. So it's pretty accurate. So that means that only 1 out of 1,000 pituitary tumors actually has surgery and is removed. Now, whether more need to be removed, that's a different question. There are a number of people who just haven't had their tumors diagnosed. But I think the reality is a lot of times we just see things in there with our advanced imaging and nothing needs to be done. But we still want to know about them because we need to do a full workup and figure out if there is an issue that we want to diagnose, or we need to diagnose. So this is an example of a pituitary gland with a very small microadenoma. So this whole thing is about 2 centimeters, and this is less than, well, this is even smaller than that, and this is about 7 millimeters in dimension. This is a microadenoma, but this is a patient who had Cushing's disease. This was back in the 60s, and unfortunately succumbed to the disease. And this was the culprit of it. This 7 millimeter little tumor was a culprit of that person's problems. This unfortunate patient had a completely different problem. This patient had a macroadenoma that had grown so large and grown through the soft tissues of the brain that it actually caused blockage of fluid in production of the brain, and the brain actually overexpanded and the patient couldn't make it. Thankfully, this doesn't happen anymore. We've gotten much, much better with our imaging and figuring out when to do it. But this is how people were years and years ago. So what are the different types of tumors in addition to the typical adenomas, the pituitary adenomas we deal with? Well, we deal with cysts like Rathke's cleft cysts, dermoid cysts, craniopharyngiomas. I think there's a couple people here who may have had that. Meningiomas, so tumors of the covering of the brain, the dura. Other cysts like epidermoid cysts, so kind of skin cells trapped in the brain. Chordomas, which is an unusual bony tumor. and schwannoma is a nerve-based tumor. So these are all different types of tumors that we encounter, and each one requires a little bit of a different approach to get to that. So that's where our anatomy knowledge comes in. And today, I'm going to try to relay some of the anatomy that we deal with to you. So by the end of the day, you guys will be able to do all the pituitary surgery you need to do. So this is a skull. This is the orient tree. This is the front. This is the back. The eyes are underneath the shelf of bone, and the nerves come out right here, and the pituitary gland lives right there in the sella turcica. So the sella meaning a saddle, and it sits there. The nerves cross over it, and the vessels, which come through these large holes, are coming around it. So traditionally, to get to this deep area of the brain, we usually make an incision in the skull, in the scalp, and take a piece of bone off of the skull and come between the lobes of the brain to get to this area. This technique works for large tumors, but for small tumors, let's see, why isn't this not working?
Whatever's lit up in orange down
Yeah,
it's lit up there.
I think you're absolutely right. Okay, thank you. So instead of going through the brain, what we do actually is we go through the nose. So the nose actually gives us a direct shot to the pituitary gland. This little saddle-like structure right here, we're looking at it from the side, sitting right over air-filled sinuses, right underneath that area. And it's a straight shot from the nose all the way back into this air-filled chamber, and this small little tumor, or sometimes large tumor, sitting right here, perfect trajectory, and we don't have to touch any of the normal brain structures. This is how we prefer to do it for most pituitary tumors. Not all of them, but I would say 95% of them, because it is just a direct shot into this area. This is just an example of all the different ways to get to the pituitary area from above. And this is an example of how we get to the area now. And we'll talk a little bit more about the tools that we use. But essentially, we go through the nose. We have a camera at the end of a stick, the endoscope that we use. And we're able to see all the structures that are critical to get to this area. This is just a diagram of how we get there. So the first part of the operation starts in the nose, the nasal cavity right here. We remove a part of this back part of the septum, the nasal septum that we all have heard about. And we get to the front of the sinus, the sphenoid sinus. That's why it's called a transsphenoidal surgery. And we get to this back of the sinus, and we remove the wall of the sinus. And once we remove the wall of the sinus, we're staring right into that area. The pituitary gland lives right there. And once we're in there, we can take the wall of the covering of that little saddle area where the pituitary gland lives, and we're staring right at the tumor or the problem that we would need to get to. This is how it was done when we started doing this back in the turn of last century. So this is Dr. Harvey Cushing, the guy who diagnosed Cushing's disease, but ironically never operated on anybody with Cushing's disease. He did this initially through the nose, and did many, many operations through the nose. I think upwards of 2,000 operations through the nose. But as you can see, he was using a coal miner's headlamp and really couldn't see that well. And afterwards, he said, forget it. And he started doing it through the brain. And this technique was forgotten about for many, many years until about 30 years later, it was rekindled. And this particular individual, Jules Hardy, guy in Montreal, really, really nice guy. And he brought in some more technology to help get there a little bit safer. The two key things he brought in was the X-ray, the fluoroscope, to give you a live image of where you are at all times. This is the first demonstration of neuronavigation, or kind of a GPS unit for the brain. And then he also brought in the microscope, which had only been introduced for surgery about 5 years before that. So with bringing in the microscope and the X-ray technology, he was able to get to these tumors safely without causing strokes, without causing visual loss. And actually, by protecting the pituitary gland, he was able to help people much, much better with much less problems. So with this advent of technology, we were able to expand that. And the next step was the endoscope. The endoscope was first introduced to neurosurgery in the 70s and for pituitary surgery in about 85. And with the technology of the endoscope improving, we were able to get to not just the pituitary gland right there, but problems all along what we call the frontal skull base. So underneath the frontal lobes, in front of the brain stem, and in between all this area, and also side to side, we were able to get to that area. And this technology really has expanded our ability to do surgery, and also its ability to do safe surgery, and be able to protect the normal gland and just go after where the tumor is. And all of these tumors that we have discussed, all are accessible with this approach. So, as I mentioned, it improves visualization, neuroendoscopy. We can look around corners. We use angled endoscopes, basically endoscopes with mirrors on the end, to look at 30 degrees, 45, 90 degrees around, so we can see what we're dealing with on the side, and we can operate around corners. So we don't have to remove all this structure, all this bone and tissue to get to where the problem is. We just kind of take a turn, take a bend. And now with HD technology, which was borrowed from James Cameron and all of the Hollywood camera advancements, and 3D endoscopy, so we actually can see this in 3 dimensions in some cases, we have a much, much better understanding of the anatomy in the area. This allows for a safer surgery, and we're able to preserve all these critical structures sitting in where the tumor was living. So this is another demonstration of why the endoscope really changed things. So before, we were using what's called basically speculums, same speculums that you guys are all familiar with, go through the nose, split apart the areas that we need to go, and with the microscope 2 feet away from where we're operating, we take out the tumor. The microscope has a good zoom, but you're really only looking down a tunnel. So it's the same concept. You can have the best microscope in the world, but so long as you're working down a tunnel, you still have the same view. You're not really able to see what's beyond that little area that you're looking at. But once you have the endoscope and you stick it in beyond that little window where you're operating, you can see a much, much more panoramic view and able to get a great view for surgery. And so this is an example of a speculum where this is a nostril right here, and we're looking at the pituitary tumor in the back. But really, you want to remove that cloud that's kind of in your way of looking at the back of the area that you're operating, and you get a much, much more panoramic view in the back part of the nose. And this is what the endoscope offers. And this is what we've been doing here. This is what I trained with in Boston with Dr. Laws and what Dr. Kelly has been doing here. And I think that really has been improving our outcomes with patients. So this is how we are set up in the operating room. We always operate with 2 surgeons, so 3 or 4 hands at any given time. And this actually allows things to be safe, but also we can tell each other, hey, be careful, don't go over there, it's a little bit dangerous, that kind of thing. We have 2 screens that we each look at. They're both in HD. And we have our GPS unit in the center there telling us where we are when we put in the wand for that. And a lot of it is about surgeon comfort. We want the surgeon to be comfortable so that after 4, 5, 6 hours, you don't get fatigued and start making sloppy decisions. Again, I mentioned it's a 3 or 4 hand operation, and it really gets us to the crux of the problem with much less trauma to the normal tissue of the patient. Now I'm going to try to show a video here, and I wonder if it's going to work because this connection's a bit slow, but we'll see. So, yeah, this is going to be a little jerky. I apologize for that. This is all on a wireless system. Basically, this is what we do. We basically make an incision at the back of the nose. And the bone that you're seeing here, this rigid structure right here, that's the back of the nasal septum. We identify that. We get on both sides of it. And we expand that a little bit. And when we do that, we're able to remove that piece of bone. By removing this piece of bone, the next thing we stare at is where the pituitary gland lives and where the pituitary tumor lives in the sella back there. And this is just a little high-speed drill, diamond bit drill, by the way, but you can't really sell the diamonds. And we're staring right now at where the tumor lives. We remove the bone, and in this case, a really thinned out piece of bone because the tumor had actually eroded some of the bone. And we're able to carefully dissect the coverings of the tumor. And after a little bit, we're able to identify the tumor and then remove the tumor from that area. Okay, so moving on to our next thing. Like I mentioned, the tools that we're using, I believe, has improved the safety of this operation. I mentioned the endoscopes. They're basically long sticks with a camera at the end of it. They use fiber optic technology. We use a high-speed diamond bit drill. We use neuronavigation, basically a GPS unit for our operation. So we know, in particular, for every single patient, where their tumor is, where their normal anatomy is, and how to make sure we avoid damaging the normal anatomy, including these critical arteries that supply blood to the brain. And we use what's called a Doppler ultrasound. Now, this is something that's very key. We basically are listening for the critical blood vessels in the area. And even if this GPS unit fails on us, the Doppler will make sure we stay out of trouble. So here we are, and this may not project well. Let's see here. I don't know if you can hear that. But here is Dr. Griffiths and myself, and we have exposed the tumor. And we just want to make sure before we make any incisions where the normal vessels are. And we can actually show a little bit more zoomed up view here, where we're listening to the arteries. The carotid arteries are on the outskirts where the tumor, in between the, surrounding the tumor, which is in between. And we use this to make sure that we make our incision just on the inside of those areas. And there you go. So that is a number of our ways to make sure we do a very safe operation and not cause any problems. So now I'm going to change gears a little bit and talk a little bit about the different ways these tumors present. Any questions so far? Any questions about the technology we use or any of the techniques that we're using? Okay. Yes?
You said a couple of slides ago you had to identify the tumor once you were in there.
Right.
How do you do that?
Well, there's a number of ways we determine what the tumor is and where it is. One is using our GPS unit, the neuronavigation. If the tumor is large enough, we're able to identify that just by looking with a particular wand. Another way is actually just knowing our anatomy. By studying the films before surgery, we know what to expect. We know where the vessels are, we know where the nerves from the eyes are, and we know where the normal gland should be. And based on that, we can come to the anatomy that we're used to seeing and determine where the tumor should be. And then once we're there, and I'll show you in some future films, you can actually tell a difference between what tumor is and what normal anatomy is. It has a little bit of a different consistency, it looks different, and it behaves a little bit differently. And we're able to use that to safely resect the tumor.
All while they're up a nostril.
Oh, wow, we're up somebody's nose. Okay, so as I mentioned, these are the different ways people can present. So let's talk about headaches. So headaches associated with tumors can have a number of different characteristics. So most people who have headaches associated with pituitary tumors are typically complain of daily headaches. They occur pretty much every day that they wake up. They're typically about right here, so bifrontal. Occasionally they can be at the top of the head. It's very rare or almost uncommon for it to be at the back of the head or the neck. Usually lasts a few hours of the day. Can be moderate to severe by pain scales. And a subset of patients, so a small portion of patients who already have headaches, actually wake up because of their headaches. So that's something that we assign a little bit more concern to, and we treat that a little bit more urgently. And very rarely, people can have what's called a severe headache, an apoplectic headache or apoplexy, where there'll be a little bit of bleeding into the tumor or cyst, and one will wake up and they talk about maybe a shotgun blast type of headache. And when we see that, that's a surgical emergency. We need to know about that and treat it right away. And the main reasons being that people can actually lose pituitary hormone function, and actually their blood pressure drops, they feel really crummy. And also they can lose vision as a result of that. So we want to be able to identify that quickly. So in a study that Dr. Laws and I had performed at Brigham Hospital in Boston, we were looking at different characteristics of patients who had tumors and headaches. And we found that something very interesting. Patients who had smaller tumors actually had more headache, and patients who had cysts had even higher severity of headaches. And I think that's a little bit unusual. Some people thought that, well, you would think that your larger tumor would be associated with a bigger headache. But I think the reality is the brain, once a tumor reaches a certain size, actually compensates for that and doesn't really transmit headache signals anymore. Whereas the smaller ones, and particularly the cysts that are pulsating a bit, can actually transmit headache a little bit more. That's just a kind of a generalization, but it certainly seems to be the case, particularly with cysts. We think that these headaches are due to the stretching of the coverings of the pituitary gland, the dura of the pituitary gland. So we think that for that, large tumors are less likely to cause headaches as they are slower growing tumors and allows for the brain to accommodate for size. And as I mentioned, cystic lesions are a little bit more likely. And as I mentioned, a sudden onset headache, again, is a surgical emergency, need to come into the hospital right away. So how do we do with headaches? Are we able to help patients? A number of studies have shown that people who present with headaches actually can improve to about 70 to upwards of 90% of the time. Best improvements are seen in patients who have headaches associated with a non-functioning pituitary adenoma, arachnoid cysts, Rathke's cleft cysts, and of course pituitary apoplexy, where you have bleeding in the gland. So I think overall, if you do have a headache and you do have a pituitary lesion, you should definitely be checked out, and potentially it can help with the headaches. And yeah, there you go. So let's talk a little bit about endocrine abnormalities. And sorry, any questions about headaches so far?
We want to make sure, like, point out that many people have pituitary tumors that never have headaches either, so.
Sure. I think only about 20 to 30% of people with pituitary tumors actually have headaches that are associated with the tumors. And that's how we try to, it takes a little bit of time in clinic to determine all of that, but that's absolutely true. So let's talk a little about endocrine problems. As we talked about, the pituitary gland is the master gland. This gland controls all sorts of different functions, anywhere from reproduction, sodium and water balance, sexual maturation, bony growth, muscle growth, metabolism, stress response, and even after birth, just for lactation and taking care of the child. All of that is controlled by the pituitary gland. So even if a few of these are affected, certainly patients can notice that and have a change in their quality of life. The way this works, basically the brain gets, so the brain actually gets inputs from the general circulation, from hormones and metabolites that are circulating in that area. And then it also gets inputs from stress, pain, fatigue, things like that. And all of that effectively controls the pituitary function. I'm going to give you a little primer about the hormones that the pituitary gland makes. They make a study of this many, many times in medical school, and as a result, we actually cheat and use some mnemonics to keep it in mind. But they basically can split the hormones that the pituitary gland makes into two sets. There's the anterior pituitary gland, which is in the front. So this is the front, this is the back. The anterior pituitary gland and the posterior pituitary gland. The anterior pituitary gland has a lot more blood supply and makes hormones that respond to what's going on in the blood, in the circulation. The posterior gland is actually a direct connection with the brain and has nerve fibers in there. And those hormones are secreted by direct stimulation from the brain and the surrounding structures in that area. So the anterior gland makes 6 hormones. And I remember it by this mnemonic, flat pig. So we're going to go over these. So flat pig. So F is for FSH, or follicular stimulating hormone. L is LH, luteinizing hormone. A is ACTH. T is TSH. P is prolactin, and G is growth hormone. So the top two, FSH and LH, are your sex hormones. They're involved in women in the menstrual cycle and after pregnancy to maintain, at least initially, the progesterone levels and maintain conception, and also are important in sexual maturation. In men, they also are important for production of sperm and also for sexual maturation. ACTH is probably the most important one. This is the adrenocorticotropic hormone, so that's the one that actually tells your adrenal glands to make cortisol. And if you don't have that, you're not going to be able to have cortisol, and you won't be able to fight stresses in life. And that's a really key hormone. And that's the hormone that's a culprit in Cushing's disease. If you have too much ACTH, you have too much cortisol, you got Cushing's disease. TSH, or thyrotropin, or thyroid stimulating hormone, that controls the thyroid glands to make thyroxine, or sorry, to make thyroid hormone, basically. And the thyroid hormone is key in improving your metabolism and just getting your energy level up. And people who have too little of this end up gaining weight, feel cold all the time, and really rely on that. Prolactin is an interesting hormone. Prolactin is a hormone that primarily is for women to produce milk for breastfeeding. And we'll talk a little bit more about prolactin because it's a little bit funny. It's controlled in a weird way. And the last hormone is growth hormone. And as you can imagine, this is the growth hormone that, for example, Lance Armstrong was accused of using. It's a growth hormone that helps with making muscles, improving bone growth, and it also affects metabolism and a number of other issues. And if you have too much of this, you can get what's called acromegaly, and we'll talk a little bit about that. In the posterior gland, there's two hormones. Antidiuretic hormone is a very key hormone. It's also known as vasopressin, or ADH, and this is a hormone that controls fluid balance and blood pressure. And if you have too little of this, you end up urinating too much, and you can't hold on to your fluid, and your sodium levels go up. You have too much of this, you do the opposite. You get bloated, and your salt levels go down. Either one is bad. Also, oxytocin is actually the hormone that helps women deliver a baby. It helps with uterine contraction. Men, it doesn't really do much that we know of, but those are the hormones that are really key in sustaining life. And the way these are regulated is called feedback loops, negative feedback loops in particular. So the brain tells the hypothalamus to make the hormone. The hypothalamus takes the pituitary gland to make a hormone, and then the pituitary gland tells the glands that it's supposed to tell, say the adrenal glands or the thyroid gland, to make hormones. And then they all make the hormones, and they go back up, and then the hypothalamus says, oh yeah, so you have this already, okay, stop making it. So that's a negative feedback loop. And so if any of these negative feedback loops are broken or not working as well, then you end up with hormone imbalance. There is one exception. The one exception is prolactin. Prolactin is a little bit funny. Prolactin relies on a hormone called dopamine, which is a neurotransmitter. You've heard about it in Parkinson's disease. And dopamine is produced by the brain, gets into circulation, and it tells the pituitary gland to not produce any more prolactin. So it's a little bit weird because that comes down the pituitary stalk, the infundibulum, the little connection between the, let me get to that little slide here. The little connection between the pituitary gland and the brain. And if you have a disruption in that area, you actually will make more prolactin. So this is something that many of you guys may have heard of, that we say, oh, your prolactin is slightly elevated or it's very elevated, and it kind of tells us a couple things. If your prolactin is slightly elevated, meaning that it's maybe around 25 to 150 or so, then you have a little bit of blockage there that's probably causing less of that inhibition and more prolactin to be generated. If you have more prolactin, it causes problems like infertility, low sex hormones, things like that. However, sometimes the tumors themselves can be producing the prolactin. That's called prolactinoma. And if that's the case, your prolactin levels are in the thousands or in the high hundreds at least. And if that's the case, you end up with, in addition to infertility, some people actually have milk production in their nipples, things like that. And all of those can be due to these two mechanisms. So we have to determine in the clinic whether is this just a mechanical blockage or is this a tumor that's producing hormone prolactin. And the reason that's key is that and we'll get to that in a sec. The reason that's key is that there's medication that can actually help decrease the prolactin generation of a prolactin secreting tumor. And as a result, you don't actually need surgery up front. So that's one of the key things we look at. We'll talk a little bit more about that. So what are the tumors that produce hormones? The most common tumor is the prolactinomas that we just talked about, the prolactin secreting tumor. Next common is the growth hormone secreting tumor causing acromegaly, or if this happens in kids, gigantism. This is if their growth plates haven't fused yet. They continue to grow and grow and grow. ACTH can cause Cushing's disease, as we talked about. And then there's these very rare syndromes, TSH-omas and ovarian hypersecretion syndrome. Very, very rare, but you can have too much thyroid hormone or too much of the sex hormones and can cause some problems. On the flip side, we can have hormone deficiency, and as we talked about, any of those systems can be affected. So, as I mentioned, the prolactinomas can cause these symptoms, and particularly infertility, loss of your menstrual cycle, headaches, bleeding into the tumor, and visual loss. But they respond to drugs called cabergoline or bromocriptine. These are basically, this is like the drugs that stimulate dopamine. They work like dopamine. And they basically tell the prolactin cells to stop making prolactin. And the tumor shrinks. So you have a large tumor, and after treatment, it shrinks down in size, and patients' symptoms get better, their vision gets better, their headaches get better, and they're maintained with medications. And we only really operate on patients when the drugs don't work, or if they can't tolerate the medications, or if there's bleeding into that area. So how do we do with these tumors? Well, with surgery, we actually are pretty good at taking down the size of the tumor. The prolactin level improves some of the time, about half to about 85% of the time the prolactin level improves. It all depends on how invasive the tumor is. Most of the time we're able to preserve normal function. We are able to sustain fertility after surgery. But unfortunately, these tumors can be somewhat invasive, and at 10 years, there's about a 13% recurrence rate. But most patients do well and are living well at 10 years. And then overall, looking at our recent literature, we're about 75 to 78% efficacious in taking these types of tumors out with surgery. So let's talk a little bit about acromegaly. So acromegaly is this syndrome where you end up with way too much growth hormone. And many of you probably know who this guy is. Anybody have a guess? Andre the Giant. And who's that guy?
Jaws.
Jaws, yeah. Both of these guys actually had gigantism, which is when you have growth hormone elevated at a way too young of an age.
Tony Robbins.
What's that?
There's Tony Robbins.
Tony Robbins, there's a few others there. There's a few others. So,
I'm saying he doesn't want to be associated.
yeah. So we have tissue growth, jaw mismatch, teeth separation, frontal bossing, sleep apnea, finger enlargement. People always complain of their ring size getting bigger and bigger, shoe sizes getting bigger and bigger, skin tags, and then we have more systemic problems like colonic problems, high blood pressure, cardiac problems, diabetes, et cetera. So it is a very serious problem. It's not just a cosmetic issue, and we definitely need to treat it. This is Dr. Ed Laws, who is Dr. Kelly's and my mentor, and this is Mary Lee Vance's endocrinologist he worked with. And I forget his name. Dan, do you remember his name? I think he was in My Giants. I'm not sure. Anyway, he was a patient of his back in Virginia. But this is gigantism, and that occurs at that age. These tumors can get pretty big. So in addition to causing hormone problems, they can cause vision problems as well, and also headaches and pituitary dysfunction. So we have to deal with the whole gamut when we deal with these tumors. All right, and this is, Dan, this is your patient. Mm-hmm. And I don't remember his name either.
Yeah.
Yeah, I thought he was a little bit of a celebrity.
I'm surprised he's a basketball player.
Yeah.
And really nice guy who came over from Senegal to actually play basketball. And he's 17 and he's 7'5". Mm-hmm. And that's Amy, our nurse practitioner,
Yeah.
on the right. And so someone was looking at him when he got here, and he actually became his foster mom runs a brain tumor center down in Orange County at Hoag Hospital. And so they got referred to us, and sure enough, he had a he had a tumor that I guess
Right.
you're going to show there. But he had very, very high, if you look at his numbers there, growth hormone normally is under, say, 6 or so. His growth hormone is 65.
Yeah.
He was, pretty classic case of gigantism.
Yeah. So, and you were asking about how we find the tumor in surgery. Well, this is a good example. For reasons that we still don't know, growth hormone secreting tumors are very white. So here is a video of us taking out one of these tumors. In this particular case, a very soft tumor, and as you can see, it's very white, whereas the pituitary gland itself looks a bit different. It's got more vascularity in it. So this is how we know. And this is just an example of this tumor that we were able to remove. Pretty much, I think we were able to get all of it. You were able to get all of it, and he was able to achieve remission afterwards. Again, I'm sorry the videos aren't playing well just because of the wireless connection of the system. So I'm just going to skip forward. So he did well here, and this is just his before and after. He had a huge tumor before, and really just no tumor left, and you can see the normal pituitary gland sitting right there with the connection, the stalk there, and proven to be growth hormone secreting tumor. His growth hormone went from 65 to 1.5, and but he didn't shrink. He stayed the same size. So how do we do with acromegaly with these tumors? Well, we do well with visual problems. Most of the time they get better, as well as a lot of the signs and symptoms of acromegaly. And the big ones are the sweaty hands, enlarged tongue, sleep apnea, diabetes, high blood pressure. Those we can do very well with. If you have bony changes, those don't change as well. That's because the bone has been set. We're able to normalize the growth hormone secretion about 50 to 70% of the time, and we're able to preserve normal pituitary function about 95% of the time. In this particular series, this is Ed Law's series, he had about an 8% recurrence rate at about 10 years. And most people are living and well at 10 years. And the key thing here with acromegaly is, and this has mostly been in the recent decade or so, there's a number of new medications out there that are very helpful for acromegaly, the somatuline and the pegavizumab, the receptor antagonist. And also with radiation, we're able to control this disease much, much better and improve remission. So even if we can't normalize it with surgery, we can normalize the IGF-1 in most patients, not all patients, but most patients. So there we go. And this is just the general literature suggesting that the endoscopic approach actually may have a little bit better of an advantage in treating these types of tumors. So Cushing's disease, and I know we have some Cushing's survivors here and Cushing's patients here as well. As you know, too much cortisol, usually well, let me take a step back. There's two things. There's Cushing's syndrome and there's Cushing's disease. Cushing's syndrome is when you have too much cortisol in your body, and it could be from taking steroids, it could be from a tumor, it could be from a number of other causes. But Cushing's disease is when you have a tumor in the pituitary gland causing this problem. And that's the one we focus on here. Typically, we see a little bit too much fat in certain areas of the body, and some stretch marks in the abdomen that are typically purple, changes in the face, and then the more critical issues, high blood pressure, diabetes, easy bruising, thin skin, things like that. And those can be really detrimental to patients, can affect them over their course of therapy. There's a patient, again of Dr. Law's, who unfortunately had long-standing Cushing's when she was initially diagnosed. She had had surgery, had a very small tumor removed, again about a 6 or 7 millimeter tumor. And then a few years later, not only did she improve as far as how the fat was, but her overall demeanor improved. It improved her mental status. She had depression before surgery, and her depression improved. So it actually really helps to try to achieve remission. Unfortunately, it is challenging. This is a very challenging disease. But when we are able to reach it, patients do well.
I wanted, Dr. Barkhoudarian, I just wanted to mention too for everyone that not every patient gets every symptom, and maybe not even 50% get the stretch marks and stuff. So that makes it kind of a hard diagnosis because sometimes doctors that aren't familiar with the disease want to say, oh, you don't have stretch marks, you don't have it, you don't have this, you don't have it.
Absolutely. Absolutely, and you can catch this in any stage of the disease. You can catch it very early on, and people have no symptoms yet, but their cortisol levels are elevated. And you catch it at a really end stage, and you really have to do close, careful endocrinological studies, which I won't talk about today, to really get down to the bottom of this and do a good diagnosis. This is an example of how we treat these tumors, and you can see, again, the tumor looks different than the normal gland here. This is a small tumor, it's a microadenoma, and we can shell out the tumor because there's a little pseudocapsule, a little capsular, a little fibrous layer that we're able to manipulate and utilize that to take the tumor out. And by doing this, we're able to identify all the barriers in there and make sure we get every last cell out. As opposed to acromegaly or prolactinomas, where by taking out tumor, any amount of tumor taken out actually helps in managing the disease. Cushing's, if you leave even the smallest amount of tumor behind, it can still cause problems. So we really aim to get as much of the tumor out as possible. So how do we do? Again, these are variable, but in this particular series, we're pretty good at taking down the mass effect, which is usually not that common. We're able to get the ACTH down about half of the time to about 90% of the time, depending on who's doing it. Everybody kind of reports their own series, but the average is about 70% of patients do get their ACTH down to normal function. We're able to preserve the normal gland most of the time, but these are tough tumors, and they can come back even if we get a cure. And we have had patients recur even 20 years after surgery. And again, because it's a little bit more of an involved disease, patients do well, but they do have some difficulties in the long run. And they're similar to prolactin tumors and with growth hormone, Cushing's disease, there are some medications out there that can help. Ketoconazole is an old steroid synthesis inhibitor. It's also an antifungal drug that has helped, but it's a very tough drug to take. And there's a new drug that had come out that recently had been shown to help with Cushing's disease called pasireotide, which was initially used for acromegaly, and that seems to help as well. It's still being proven, but we have been starting to prescribe that to our patients.
And we have another, there's one newest drug is
The Korlym,
that
right.
is also doing well.
Yeah, I didn't want to mention that, but that's absolutely true. Korlym works in a very interesting way. I won't get into the details, but it has been shown to help in a certain subset of patients, not every patient. And again, we don't have the best results. It also shows that because these are small tumors, it doesn't matter what tools you use, the disease itself is very tough to cure. And everybody kind of has varying success rates, but about 75 to 80% success rate here. So we'll skip this part here. These are those rare tumors here. And I mentioned about pituitary dysfunction. So again, if you have a non-functional pituitary gland, or if you have a pituitary tumor that is growing and growing and producing hormones, it could still cause compression of the normal pituitary gland. And occasionally this can happen after surgery just as a result of manipulating the gland upwards of 30% of the time, but usually about 10% of the time. The hormones affected are the ones that we've been discussing, and this is kind of the order that they occur. The first hormone to go is typically the sex hormones, then growth hormone, then thyroid, and then the cortisol-producing hormones. And we recognize that, and we try to treat that before and after surgery. Also, occasionally patients lose their fluid function, and we get to a problem called diabetes insipidus, or an inability to control the amount of fluid in your body, and that's due to a low production of ADH, or vasopressin. Sometimes right after surgery, we get the opposite. You get too much of this hormone being produced, and your salt levels go down. And I don't know if any of the patients who've had surgery here, did they ever have a sodium level drop after? No? You did? You had it before. Yeah, so some tumors can actually present beforehand, and we've actually seen that in a number of patients. And you had it afterwards? Yeah. We still don't know why it happens. It happens reliably in about 5% of our patients, and they need to come back to the hospital about a week later. But it's always temporary and gets better. All right. Any questions about hormones? I threw it all out at you guys. There's a lot of information, but just kind of a little brief overview. Any questions about all of these things? Yeah?
Do the tumors, pituitary tumors, increase the secretion only, or they can decrease as
The tumors can also decrease hormone production because it compresses the normal gland. So if the normal gland is compressed enough, then it won't be producing enough of the hormones. And as I mentioned, probably the most common one is your sex hormones. Women have amenorrhea or they lose their periods, and men have sexual dysfunction.
With Cushing's syndrome, is it more of a diagnosis of exclusion for you, or is it a definitive lab test that's going to confirm that overwhelmingly?
We actually spend a lot of time before surgery doing a number of lab tests to really make sure we have a good diagnosis. There's some screening tests that we look at, so just in general your cortisol level and your ACTH level and your circulation, but they vary hour to hour and at what time of the day you measure it. If you measure it early in the morning, your cortisol levels are higher normally than in the evening. So we actually want to measure these levels at night when they're supposed to be low. And if they're elevated at night, then we do urine tests, and then we can do some other tests to follow that up.
So what are the popular cortisol tests that you generally like to do?
Right. So a good screening test is what's called a midnight salivary cortisol. So we just take a little brush swab and we send it to the lab and we check that for cortisol levels. If that suggests that is elevated, then we would do what's called a 24-hour urine cortisol level. So we want to check your urine for 24 hours and we see how much cortisol your body is producing. And if that's elevated, that's typically consistent with Cushing's disease. Sometimes if that's equivocal, we'll check it twice or 3 times. That's generally the way. There's also something called a dexamethasone suppression test. That's key to determine where this cortisol is coming from. Is the ACTH coming from the pituitary gland, a tumor in the pituitary gland, or a tumor elsewhere like in the lung or something like that?
That's more directional of where it's coming from.
Exactly.
Than the elevated levels.
Well, it can check and see why the levels are elevated. So if you give a low dose of dexamethasone, just a typical hormone, a typical steroid, it should drop your cortisol levels down. If it doesn't drop, then you probably have production of it from other causes. Then we give you a higher dose of that, and if it still doesn't drop, then it's probably coming from outside the pituitary gland. So those are the 2 different ways we check it.
Okay.
Yeah.
If fellows are interested in this information, is it possible to get this PowerPoint presentation or anything?
Absolutely. I'd be happy to give this to you guys if you'd like. Although the videos are not playing as well, but you can.
Make a list and write down our emails or something.
Absolutely, we can do that. Okay. All right. So let's change gears a little bit and talk a little bit about vision. So this is actually some of the more urgent types of causes of the need to go to surgery, and also we are always very cautious about this and very cautious about where the nerves are to the eye and how we treat the tumor when this is the case and how patients do afterwards. So as I mentioned, as the tumor grows, typically it doesn't grow down because there's bone in that area. The tumors grow up because there's softer tissue. And the first thing it hits are those nerves to the eye, the optic nerves. And as a result, people get damage to the nerves to the eye. And these are typically non-functioning tumors. And when that occurs, the first thing that goes is their peripheral vision. Just because of the anatomy of the nerves, their peripheral vision goes, and they're only getting tunnel vision. Many times, patients don't notice this because your brain accommodates to this very well. It's such a slow-growing process that it may take a year or so of this going on before you say, hey, you know, I thought I was seeing much better a year ago, but I can't see that well now. So oftentimes we find this as a second diagnosis when we see a patient in clinic. So mastocytosis of the tumor can cause visual loss. And the whole science behind why you get tunnel vision has to do with these crossing fibers in the center. Basically what happens is you have a tumor here, and these crossing fibers, the X in that area, gets compressed first. And those get the visual fields from the outskirts of the world. And that's why you kind of get a constricted visual field. Sometimes these tumors can be in front or behind of this area, and you get a little bit different presentation, but typically it's tunnel vision is what you get. You can also get double vision. And the reason you get double vision goes back to the slide I showed. Here's the nerves that come from the eye, but all these guys here on the sides, those are nerves that control the muscles of the eye as you look left and right and up and down. And if you get damage to these nerves, then you can lose that function. You get double vision. And oftentimes it's just from compression, and we can take out the tumor and patients do better. So what are some of the symptoms? One of the symptoms we see is this kind of washed out picture where you see this image, but the color is gone, and maybe there's a little bit of a smudge where you're actually trying to look. And these are very subtle, but they can be one of the first findings of these types of problems. Then we also have visual acuity loss. So people, despite the best glasses, are seeing at 20/50, 20/70, 20/100 in one or both eyes. You lose ability to determine color vision, so you're not able to find the numbers that are hidden in these circles. And then you can actually have receptive problems with how the eyes conduct light. And ultimately, you have this tunnel vision, visual field deficits that we test for in the lab, in the office. These are visual fields. These are what we look at when we evaluate patients with these types of tumors. This is a normal visual field. These dark spots are the blind spots, the normal blind spots of that exist in everybody. And in this particular patient who had a large tumor, they actually had complete loss of vision on both sides. So they had complete tunnel vision. There's also some, I won't skip this part, there's some variations to this theme. But for the most part, that's how patients present, or some variation of that. In addition, we can have double vision, as I mentioned. And typically, this is side-by-side double vision. Occasionally gets better, sometimes gets worse by fatigue. And sometimes they're a little bit crooked and people correct their heads. So if you see somebody walk around with their head tilted, they may have a pituitary tumor, and we need to evaluate them. If you have double vision when you close one eye, it's not because of a pituitary tumor. It's probably something going on in the eye itself. This is only when both eyes are open that you see two different images and you get double vision. So how do people do on who have visual loss, who have surgery? Well, it all depends on how long their visual loss has been, how bad the visual loss has been, and what the cause is, if it's compression or if it's invasion of the nerves. And if we see nerve atrophy, that's always a sign of concern. This is a study from the 70s, but it still holds true today. That really says that we can turn back the clock about 6 months. So we ask patients, how well were you seeing 6 months ago? Oh, I was feeling fine. So, okay, well, we will probably get you back there. It's not going to be immediate. Usually it takes a few months for the nerves to come back, but that's generally where we get them to. We also now have this tool called optical coherence tomography, or OCT. You may have heard about that. And basically, it's able to measure the thickness of the retina. And we're able to see if there's any evidence of atrophy. And we can track this in patients and see how they do and how they improve. And we're actually studying this in the lab here at John Wayne to see how patients do after we take their tumors out with this technology. So this is our last video I'll show you. And basically, this is a patient who presented with vision problems and had a very, very large tumor, really firm tumor, and wasn't producing any hormones, but was certainly causing problems. And we were able to come around this entire tumor, and then ultimately we were staring at the normal blood vessels in the brain and the normal structures in that area. But after surgery, the patient's vision almost immediately got better. She woke up and said, oh my God, I can see so much better. And actually, after a month or so, she was almost back to normal. So you see people who have a hard time with seeing, they can actually get better, and it's not the end of the world for them. And we're able to help them with these. So, and as Sharman was mentioning, occasionally none of these symptoms happen, and these can be due to incidental findings. And some people come in and say, oh, I have an incidentally found pituitary tumor. Sometimes that's true. Sometimes it's not incidental. They just don't recognize the symptoms of all the things that we just talked about. So if anybody has a tumor, you should definitely have them be seen by a pituitary specialist, at least an endocrinologist or a neurosurgeon who specializes in that area, as you guys all know, because we see enough of this to recognize even the more subtle symptoms of these problems. And with that, I'll open the floor up to questions. And of course, if there's any comments you guys want to add, feel free to say that as well. But thank you very much. Thank you for your time.
Thank you.